Thank you guys for being here today. Just as a reminder before we get started, this is a recorded webinar, and by staying on, you're consenting to be recorded. This will be on our website and be available to share in the next couple of days. Good morning, Kim. I didn't see you join. Hey. Okay, just want to introduce myself. I'm Caitlin Johnson. I'm a project manager for ABIN. And I get to introduce today because Kim is traveling and she's presenting on one of our grants. We're very proud of her and can't wait to hear how it goes. So I'm going to go ahead and introduce Dr. Thompson and then we will let him take it away. Dr. Joe Thompson is a nationally recognized leader in the quality and financing of healthcare, public health improvement, and strategic responses to public health threats. As ACI's President Emeritus, he leads innovative efforts to address emerging and legacy health issues through individual choice and influential policy. With funding through a National Science Foundation Engines Development Award, Thompson is leading a partnership in the Mississippi Delta regions of Arkansas, Mississippi, and Louisiana to develop a proposal for an initiative to transform one of America's most disenfranchised areas into a thriving, diverse, and integrated economic driver. He is also a co-principal investigator on a first-of-its-kind study funded by the National Institutes of Health to assess the impact of medical marijuana here in Arkansas. Thompson has led vanguard state and national efforts in healthcare financing reform, health promotion, and disease prevention efforts focused on health threats from tobacco and obesity and emergency response efforts during periods of crisis. As Arkansas's inaugural Surgeon General, he served in administrations of governors as Mike Huckabee and Mike Beebe. Dr. Thompson, we are so excited to have you here today. I'm going to hand it over to you.
Thank you, Caitlin, and thanks everybody for being up early on Thursday morning. I see a lot of friendly names and faces and just want to thank everybody for your support over time. And I think we've got some choppy waters that we're going into that we'll need to pull together to help make things happen. On with me is Michelle Kitchens. I think many of you know her. Michelle is our Director of Governmental External Affairs, and she's helped get me here and continues to help me be places I need to be. But in follow-up, if you have any questions, I mean, Michelle can get to me or she can answer many of them. We have an enormous number of assets on our Arkansas Center for Health Improvement website that I'll mention, two of them of which you may be of interest in. We have two different mental health dashboards that let you drill down to the county level to look at many of the health statistics and information that I'll provide you today. So with that, let me kick us off. Caitlin, I think I can, do I share? Yes.
I was going to say, you should be able to share.
All right. I am coming to you, I think.
There you go. It's working.
Now I got to find my PowerPoint and get that. I'm on my laptop, so it's not quite as facile as I usually am with this. There we go. Slideshow. So this is going to be a pretty fast run. My title has a pretty broad scope, and so we're going to fly at about the 30,000 foot level. But I intentionally did this with Caitlin and others' consultation to help share with you the resources that we have available as we go into some of these, I think, tough discussions on Medicaid, on the role Medicaid plays, on the support that both Medicaid and the commercial sector need to provide in the behavioral health aspects, and then some new and emerging, I don't know if they're threats or opportunities. We're studying the medical marijuana effort to see. The learning objectives here are really kind of focused on these three areas of acute maternal behavioral health, social media, and then medical marijuana. So, we'll go pretty quickly through here. I think most of you know our center. We've been around over 25 years. Our mission is to be a catalyst. A catalyst is something that rarely does anything by itself, but doesn't get burned up in the process. And so far, we have been successful in that. And we've enjoyed working with many of you in different areas and different aspects. Our focus really here is on three different areas. Originally, in our first 10 years, it was mostly on health systems, on access to care and the quality of care. We've increasingly, over the last decade, recognized that it's the community within which people live, work, and play, and also the choices that they make within that community. So we've broadened our scope. There's probably not anything on the health or healthcare waterfront that we haven't at least participated in an aspect at some point in time. The real asset that ACI builds off on is our data assets. And over the 20 years, we have built what really is a unique data asset that is unequaled in the United States. we have, over the last 10 years, for most Arkansans, a unique encrypted ID, not their personal identifiers in any way, but a unique ID that we have linked to, on the top part, the Arkansas All Payer Claims Database. This is a mandatory database that all the commercial companies have to report their information to. Medicaid and Medicare report to, employment benefits, state employees report to, Medicare does. And then if you go around the clock, we have pulled in the hospital and emergency department discharge data from the health department, the cancer registry, the state police crash data, the death certificates, the medical marijuana work, birth certificates, COVID, children's BMI data over time in schools. And so this really is, if somebody asks me what ACI does, we take data, we turn it into information to try to inform decision makers to help them make better choices. When we look at what we have covered, this is kind of a coverage pie. We've got all of Medicaid. We don't have TRICARE and VA. We do have the uninsured and the hospital and discharge data. We have the EBD data. We have the commercial data. We have the commercial qualified health plan data. We have the Medicaid expansion population. We have the PASS population. We do not have the Walmarts and the Tysons of the world, but we do have Medicare Advantage, Medicare fee for service, and the dual eligibles in our line of sight. So we think we have line of sight on about 85% of all Arkansans and of everything that is spent on Arkansans in the state of Arkansas. So let's jump in on our efforts, and this is again at a pretty high level over behavioral health patients and payments analyses that we have been doing over the last couple, 3 years for the Department of Human Services and their Division of Behavioral Health. All of the work that we have done has been put publicly on our website. And so, all of this is not hidden information, but it is information I think that helps profile the behavioral health landscape in Arkansas. And when we look at all enrollees by Medicaid programs and on the left, commercial programs on the right, Medicare programs commercial in the middle, Medicare on the right. Medicaid has over 1.25 million enrollees. Commercial coverage is about 750,000. Medicare coverage is almost 700,000. And here you'll see the red component of these bar charts are those enrollees that have a behavioral health diagnosis. It's about 19% of the Medicaid population, 14% of the commercial population, and about the same for the Medicare population. When we look at what is spent, Medicaid is by far the largest payor for behavioral health services in the state. Over 3/4 of the payments that go to providers are from those Medicaid programs. Now, that's not only because they have a larger number of patients, but they also care for a sicker tier of individuals. But again, when we think about from a strategic perspective on provider networks, on building out support, Medicaid clearly is a major driver and an important partner in being able to do that. When we look at adults, so this is now restricted, kids are not in here, it's only adults. It's even a slightly larger proportion of the Medicaid enrolled individuals, almost 20% with a behavioral health diagnosis. And then again, about 14% in the commercial and in the Medicare population with a behavioral health diagnosis. When we look at those individuals, however, we see that the severity and the expenditures are much higher here in the Medicaid programs over time. We do see a slight reduction over the last few quarters. The Medicare orange line in the middle stops in fiscal year 23. We have a 1-year lag on data there. But you can see that these are the individuals in our state under these different payor groups that have these needs with a paid claim for each of these quarters. But what's paid is markedly different. Medicaid pays much more in the total scheme of things than either the commercial or the Medicare counterpart. The children's snapshot does not look too different. A majority of kids are on Medicaid. Probably 2/3 of the kids in our state are covered by Medicaid. 17% of those have a primary behavioral health diagnosis within the year. On the commercial side, it's a much smaller, only 13% have a behavioral health diagnosis within the year. So again, this is kind of a snapshot trying to say, okay, for our covered lives in the state, who is covering them? Number one, what's the behavioral health prevalence? Number two, and then where are the payments coming for those individuals? Number three. We see the same kind of disparate number of individuals with a primary behavioral health diagnosis. Now, there are many behavioral health diagnoses that are in the secondary um, diagnosis within claims that come in. Almost all of what I'm sharing with you here today are individuals for whom the primary reason the patient was seen was for a behavioral health diagnosis. So here are the kids, within a quarter, 56,000 kids being seen within Medicaid for a primary behavioral health diagnosis, about 10,000 for commercial. And again, contrary to the adults, the amount of claims paid for those behavioral health diagnoses in terms of total costs are going up for Medicaid over the last 3 years, while they're staying relatively flat in the commercial sector. This may be because we have more stressors and more mental health conditions being diagnosed, or it may be because we're having more critical impacts from those external circumstances that we've experienced over the last period since COVID. We spent a lot over the last 2 years in the maternal health space, being a data resource and providing, issue briefs and targeted analyses for the governor's team in the maternal health space. And I think we have really discovered something that has been under the radar screen for many, if not most of us, which is a significant mental health load that we have for our moms. We developed, because there was so much focus on maternal mortality, we actually developed a birthing journey to say it's not just about the deaths of the moms, but it's about their experience throughout their birthing journey. We are 50th, 51st, 49th in maternal mortality, but if we avoided 10 or 20 of those deaths, we'd be number 40. So this is, small numbers, critically important, but we think that the solution is not focusing just on maternal mortality, but actually the health and the experience of the mom throughout her birthing journey. So we really looked at the pre-pregnancy kind of preparation. Is the mom in a healthy state? Is she got social support? Does she initiate prenatal care, the second one there early? Does she get education and support? What's the safest method of delivery? We see the medical care system having a very high variation rate in terms of the use of C-section. So we are trying to push on our medical side to have less unnecessary C-sections. On the right then, the postpartum care, I think important here for this group, the depression screening, for which Medicaid and Blue Cross have put in new paid claims for depression screening in the prenatal or in the postnatal period. Home visits, we've got new both doula and community health worker efforts underway, making sure that the clinical medical side does execute those postpartum visits, and that we get the baby into the appropriate well child visits. But we looked at kind of the maternal health of moms, and we developed a construct. We looked in our study that we did for DHS from January of 19 through June of 22. We looked at the mom's prenatal period, 9 months before her delivery, the birthing experience, and 1 year postpartum. And we looked at her infant's experience in that first year of life. We defined kind of an acute behavioral health event, and this is a serious acute behavioral health event, as either an emergency department visit or a hospitalization inpatient with a primary diagnosis of either a mental health or a substance use disorder. So this wasn't somebody coming in with a medical condition who also was depressed. This is somebody whose primary reason for the visit or the hospitalization was a behavioral health disorder. The index event was kind of the first acute behavioral health event, or the first emergency department or hospitalization in the observation period. We used the health department's hospital discharge data so that we did not miss any mothers. This is inclusive now of all mothers in the state, regardless of their enrollment status. And then for those who were in the all-payer claims database, and again, for our moms and our kids, we think we're probably over 90% covered in the claims data. We extracted claims data to calculate kind of total medical expenditures for mothers and infants and to look at follow-up periods for them. Some of the data I won't present today, but it is on our website. I would encourage folks to go there, particularly for the follow-up on moms, which I'll mention here in a few minutes. Our outcomes is we wanted to look after the acute event. What did their subsequent ER visit profiles look like, or their hospitalizations? What's being spent? And then again, we looked, at the mother's complete period, her birthing journey, and the infant's life in his or her first year of life. So we found 119,000 deliveries over this 3-year period. Of those 119,000, we could link the moms and the babies on about over 98% of them. The linkage issue is a little bit of a challenge in the data space because the birth certificates are good, but they're not perfect. And in the healthcare insurance, mom and baby end up with a different insurance number pretty quickly, and we have to figure out how to link them back. But surprising to me, anyway, was that of our mothers, on the bottom left, 4,400 of them were seen in the emergency room or were hospitalized in their prenatal or their postnatal period. So almost 4% of our moms are seen in an emergency room or hospitalized. The number breaks down roughly the same, 1.8% in the emergency room, 2.2% hospitalized. But again, I was surprised that, almost 1 in 20 moms have an acute behavioral health event that result in an emergency department visit or a hospitalization. When we look at the time of those events, many of them are prenatal. Some are recognized during the birth event, but most are in that first year postpartum. 40% are in that 1 year postpartum period. You can see here a majority are mental health events, with a smaller number being substance use disorder, and the larger proportion, not a majority, but a larger proportion of the substance use disorder being identified during the birthing event. Now, I won't show this here, I don't think. Let me see what we do have here the percentage of deliveries associated with these acute behavioral events by county. And it ranges from, no percent in some of our lower populated counties to as many as 8% of mothers that deliver there in the Southwest being hospitalized for an acute behavioral health event. I won't show this, but this is of concern. And again, the county specific numbers are available on the dashboard and in some of the reports on our website. But of moms that are hospitalized, 50% have no evidence of follow-up after discharge from the hospital in 4 months, 120 days. That's zero, no evidence of follow-up in 4 months after discharge. So I think there really is an opportunity for us to recognize the acute behavioral health event as a signal to, wrap case management around, to recognize, better discharge planning, so that these moms are not falling through the cracks. And I'll share with you some of the results of that failure to follow up in a few moments. Of our moms with acute behavioral health events, they're a little bit younger, the 20 to 24 year age range being the median, the most likely. On the right are moms without acute behavioral events. Now, these are not moms necessarily without behavioral health issues. They just didn't require hospitalization or an ER visit. So the ones on the left are those more severe women that required a hospital visit or an ER hospital admission or an ER visit. Slightly more likely to be Black, slightly less likely to be Hispanic. This may represent access issues more than true differences in race and ethnicity. When we look at the payer distribution, who had these mothers at the time of delivery, Medicaid had about 60%, but the commercial coverage was about 40%. And you can see the slight difference there. Again, Medicaid carrying a heavier load for those with behavioral health issues. I will say in that follow-up statistic that I just mentioned, after hospitalization, the commercial coverage and the Medicaid coverage are dead even. Neither gets better follow-up. Both fail to get follow-up for moms 4 months after hospital discharge at a rate of over 50%. When we look at emergency department utilization for mothers with and without acute behavioral events, so this is looking at those moms needing emergency department utilization. There are moms without these acute behavioral events that do seek care in the emergency room for various reasons. It's almost a 2-to-1 ratio of those with a behavioral health event to those without. And so again, these are mothers in need, and turning to on the left, the emergency room as a frequent source of care. I don't know usual, but frequent source of care, far more frequently than our moms that do not carry that previous inpatient or ER utilization for behavioral health. Once hospitalized, then it really does ramp up. If you end up with an acute behavioral event, the likelihood of you using the emergency room subsequently, 40% of overall of moms that have had an acute behavioral event will subsequently utilize the emergency room in their birthing journey, where only 8% of moms on the right will end up utilizing that emergency room for a source of care. And you can see the distribution here in the prenatal period and the postnatal period. I think that postpartum depression, the postpartum challenges in the mental health space are evident on the left in that postpartum period. When we look at hospitalization, so this is of moms that had at least one. Now we're looking at the utilization rate for moms between those that have an acute behavioral event previously and those without. And so you can see here the difference in if the moms go once, many of them go multiple times. So it's 660 hospitalization events per 1,000 mothers overall on the left, or where it's only 100 hospitalizations per 100 mothers on the right. I think I've got ER visits next. No, I don't. So, and when a mom is hospitalized, we see the mental health diagnoses coming through on the left. Again, these are moms that previously had an acute behavioral event. When they're rehospitalized, it's the number 3 reason is depressive disorders. And then we have the psychotic and the bipolar disorders, again, probably depression related, as 3 of the top 10. These do not appear anywhere, on the right, with mostly postpartum related or chronic disease related issues on the right. So again, this is evidence for opportunity, but evidence for needed investment to make these differences happen. When we look then just in the postpartum period, the top 3 diagnoses become depression, psychotic, and bipolar related. So the top 3 reasons moms that are hospitalized in the postpartum event or following an acute behavioral event is their mental health condition not being adequately controlled or under control and resulting in a subsequent additional hospitalization. Now, when we look at the infants of mothers with and without acute behavioral events, we start to see the impact, the spillover impact of the maternal mental health issues. And of course, these babies are born probably into a family that has already been stressed by different both environmental factors and potentially either recognized or unrecognized mental health factors in the mom. But then that infant is not born with any specific acute diagnoses necessarily. And so we looked at the ER utilization and hospital utilization for infants of moms with and without acute behavioral events in the birthing journey. We've had 121,000 infants. Again, that we had a high success rate of linking them to their mothers. And again, of the moms, about 3.8% had a behavioral health event and the 96% did not. So we'll look at those infants of these mothers. So the percent of infants with at least one event, you can see the emergency department, over half of the infants had an emergency department visit. About 10% of the infants of moms with an acute behavioral event had a hospitalization. Of even the moms that didn't have, it's still a pretty high proportion. And again, I would remind us that these may have underlying mental health issues in the mom that she just hasn't necessarily presented for an acute behavioral event, a hospitalization or ER visit. There are other reasons, many other reasons, that kids go to the emergency department in the first year of life, particularly if it's a first-time mom and need for either acute assessment or sometimes it's maternal education. But again, a slightly increased rate of hospitalizations. Interestingly, of kids hospitalized for in that first year of life, 3 of the top 10 primary diagnoses for moms that had an acute behavioral event could be related to that behavioral health issue: maltreatment or abuse, feeding disorders, or malnutrition, again, being 3 of the top 10 reasons that kids or infants are hospitalized in that first year of life. You'll see the most common or fairly shared, respiratory challenges, bronchitis, jaundice, hyperbilirubinemia, infections. But then the only place that some of the maltreatment and feeding disorder issues showed up were on the moms in the top 10 that had a behavioral health event. So in summary of our findings, and again, I would encourage you, and Michelle can help set up, if you would like, a tour of our dashboards. They don't work very well remotely on a presentation via Zoom. They work incredibly well when you're sitting in front of your computer on the internet. But we have a dashboard for overall mental health expenditures that drills down by county, by payer, by number of enrollees. And we have the mental health dashboard, which are the results that I've drawn from here. Summary of our findings, just to give you the bullet points. Moms with an acute behavioral event, that is, that she's been either hospitalized or seen in the emergency room, were 4.9 times more likely to be subsequently hospitalized in the observation period compared to moms without. They have 6 times more hospitalizations compared to mothers without. 3 of the behavioral health diagnoses in the top 10 were during the prenatal period. And actually, I failed to show, no, I did show this. In the postpartum period, the top 3 categories for hospitalizations are behavioral health related diagnoses. The infants of moms with acute behavioral health events were 20%, 1.2 times more likely to have a hospitalization. If they had a hospitalization, they were 1.2 times more likely to have more hospitalizations. And those diagnoses for child maltreatment, feeding disorders, and malnutrition were in the top 10. So before I go here, let me just pause on, and we can have some discussion, and I would invite that discussion. In the national dialogue on the proposed cuts to Medicaid, the disproportionate responsibility of Medicaid for our mentally health diagnosed individuals is going to be a real threat. And I think we need to organize and figure out kind of impact assessments so that our state, if we're forced to make tough decisions, we make them informed and with as much information as we can. What we're trying to do is to show that we have the ability through that acute behavioral health event, the kind of initial hospitalization or ER visit of the mom, to be able to wrap resources around her to potentially avoid both downstream clinical outcomes and the associated costs with both the mom and with the baby. So be open and interested as we come to the discussion to have your thoughts and comments on opportunities there. Let me move to another major effort that we've had. I've been in front of several, boards of the education department. We are actively engaged with the Superintendent's Association. I frequently get asked, before COVID, it was vaping in schools. After COVID, it really is mental health in schools and even suicide attempts within schools. And at least a component of that increasingly recognized are the social media influences on kids in schools. So for the last 2 years, 3 years, we have really had a focus on youth mental health and safety in the online age. These are going to be some select slides cut from a full hour-long presentation, but I think they hit the high points and again stimulate, I hope, your interest in engaging together so that we figure out what we can do going forward. I want to, if we were together, I would ask for a poll and the raise of hands. When did the iPhone or the smartphone, we'll start there because there are different versions, the smartphone first came out in what year? Let me ask you to write that down on a piece of paper, or at least in your head. Before that, we had flip phones and we could text and we could take photos, but those were dumb phones. They weren't attached to the internet. So 2007, that's right, 2007. When was the first time you had a video camera on an iPhone? Any guesses? 2000 is either 2010 or 2011. So I just want you to pause and think. All of the video stuff we have on the web now, all of the apps, all of the mechanisms have happened in the last 15 years. And so this is just an explosion of a new media for which through the smartphones, our kids have complete and open access to anything and everything on the internet. And we have allowed iPhone access into grades as low as elementary school. So we should not be surprised that we may have some new challenges that we haven't faced before. And those challenges are pretty sobering. 95% of teens report using social media. More than a third say they use it almost constantly. 40% of kids 8 to 12 now, are on social media platforms. 8th grade children spend an average of 3.5 hours on social media, some of them spending more than 3 hours a day after midnight. 1 in 3 kids report using it until midnight or later on a typical day. 64% say they're often or sometimes exposed to hate-based social media content. 60% of adolescent girls say they've been contacted by strangers who made them feel uncomfortable. Again, I think I get contacted by strangers that make me feel uncomfortable. I don't want our teenagers having the same thing. 47% of Arkansas high school seniors, report symptoms or feelings of prolonged sadness during the 2019-20 school year. Now that was during COVID. Or at least the initiation of COVID. And COVID provided a number of other factors here. It drove kids to use, digital media for educational purposes. But I think as our schools turned to digital media, we probably didn't think enough about digital safeguards in that process, and even accelerated more the interactions of our kids through digital media with the broad and wide open internet access. What do we know from the data? We know that this is really a change in the style of communication. This is from Jonathan Haidt's book, The Anxious Generation, which the governor has spent a lot on. The superintendents, I think, have really embraced. What I found in it, which was very, very helpful for me to think about from a mental health perspective, is that this different form of communication has some very specific characteristics that can be identified. Let's just go before the cell phone, because we're all affected by it now, but we were pretty committed and required synchronous conversation, whether it was telephone, whether it was in person. We interacted with somebody in a real-time way. And usually there were verbal and nonverbal cues that were part of that communication. And most of the time, it was a one-to-one or one-to-several communication. You were in a smaller group, and that smaller group had relationships that had a relatively high bar psychologically and emotionally for entry and for exit. Um, this was the way the world used to be. The way the world is today in the realm of social media, and I think this is true for adults as well as it is children, it's really asynchronous. You throw your thoughts out on a social media and you wait for a response, and you don't know necessarily who the response is coming from. It's disembodied. You're not getting verbal cues. You're not getting visual expression. You're not actually getting the emotional connection through the virtual world communication. The relationship is one to many, if not one to all. And your entry and exit relationship threshold for emotional and psychological investment is really pretty low. You can friend somebody or defriend somebody with a left or a right swipe. And that cascades into how that other person receives your decision to enter or exit the relationship. So I found these two to be really helpful in explaining what has changed. Now, looking at data about what it looks like that change has caused, is we think there are differences in brain development because of youth hypersensitivity to these social feedbacks. The likes and the follower counts directly feed back onto your amygdala for positive and negative social feedbacks. The tailored ad content targeting our young kids, that are already predisposed to peer influence, affect their frontal cortex. The AI recommended contact, which, scrapes what the kids are looking at, enables prioritizing targeting, which reinforces the tailored ad contact in the second bullet. Our impulse control in youth is relatively underdeveloped. And this probably extends into early adulthood and may extend for some of us into later adulthood. The infinite scroll where you're constantly looking can easily become a dependency, if not an addiction. It's difficult to disengage. The lack of time limits for our youth result in direct competition for time for schoolwork or sleep. So there are interruptions there. The push notifications that almost every app asks you to enable capitalizes on youth sensitivity to distraction. And then I think it's unrecognized by most of us and completely unrecognized by our youth is that everything they're putting out onto the web is retained forever, and that it allows exploitation and a lack of appreciation for their long-term consequences. And we see these differences in the numbers. Research shows that 12 to 15-year-olds who spend more than 3 hours a day are twice as likely for depression. Studies linking social media use to life satisfaction.
Morning.
Dramatic rise in depressive episodes. And I go back to that date of the video camera going in the now internet-enabled iPhone. That's about when we started seeing, at least for girls in particular, this dramatic increase in depressive episodes. We also see the same for self-harm episodes, disproportionately present in our youth, our girls. Again, I think this has been a call to alarm. We've had a Surgeon General's advisory trying to raise this awareness in 2023. I won't read these to you. They're fairly high level, fairly non-actionable. There are tools that are on your phones of your youth that I encourage in every interaction that I have for parents of adolescents to, take an active engagement. See, you can look at the breakdown of screen time and activity by different apps. You can schedule when the apps are not available on the youth's phone. You can schedule time limits. You can subject the youth's phone to parental oversight with a linkage with the parent's phone. You can do all of these things. You can set the passcodes that only you can change the settings. Now, I will tell you, kids are smart. And the single place that they are outwitting parents on these modern monitoring tools, and I would challenge each of you to think of it, how many of us have an old cell phone in a drawer somewhere because we got a replacement phone? Our kids are really good at finding those ghost phones, getting them connected to the internet via a network setting in somebody's home, and then all of these restrictions are lost. So Another bullet that I should have put on here is for parents to change, the network passcode, and this messes you up on the TV and everything else, but at least on some basis, every 6 months or so, so that you have some ability to know. I think it is important to talk to your children, to adopt social media practices, to talk to them about blocking unwanted or inappropriate contact, to reach out if they see harassment, understand cyberbullying, and importantly, not share any personal information online. Watch for warning signs, disruptions, acute disruptions in relationships, schoolwork, mood changes, habit changes. This is my social media uh, prescription that I've tried to give moms: engage, socialize, education, participate, and prioritize. With the kids in the family, build a media plan, figure out when you want your child to start having access and then graduate that access. Balance times with and without devices, talk about the experience, set a good example, tailor your online experience. And I think most importantly, play zone defense. Talk with the parents of your children's friends. And if y'all can all have the same rules, it makes life a whole lot easier than playing one-on-one. We do have some action in our last General Assembly, and we're looking forward to seeing the impact of the bell-to-bell phone restrictions. I anticipate that we will get parental pushback on that, and so I would really ask for each of you to be actively engaged in the school board discussions of your local communities, to advocate for the importance of putting in place these cell phone restrictions, at least during the educational period, to help protect and support the educational time that our kids so critically need. There are more resources here. I'll be glad to share the slide deck, but there are resources out here for parents and for caregivers and others to use. Most of these, again, we've got a landing page on our website for social media and youth mental health. I'm going to go quickly to give us some time to talk here, and I'll try to wrap this up in the next 8 or 10 minutes. Arkansas had a unique opportunity because of those data linkages that I mentioned at the outset, because Arkansas has done medical marijuana only, not recreational marijuana yet. And so with colleagues at the UMS, colleges of medicine, pharmacy, and public health, we put in an NIH grant to try to say, okay, what does medical marijuana do? Nobody really knows. Our medical marijuana program, it's been in place since 2019. We've got 38 dispensaries. To get a card, there is no real requirement for clinical integration. A patient gets a form from a licensed physician. The state issues the card. The card holder can buy up to 2.5 ounces of usable flower. The cultivation is highly regulated, but not the access of the product by individuals. There are 18 qualifying symptoms. I'll tell you now, the most frequent is PTSD. We think that's probably because it has the least documentation. If you add the pain, intractable pain, let's see, we're at intractable pain, arthritis, and peripheral neuropathy together, those three become more common than post-traumatic stress syndrome. Here's the distribution. Sorry, I jumped ahead. I didn't know that I had left this slide in. This was for 2021. About 20% have 2 or more diagnoses. You can see PTSD and the pain diagnoses represent the majority. Get down to cancer, it's only about 4%. And on the left-hand side, really small numbers on some of the other qualifying conditions. This is the uptake over the first 2 years of availability. You can see that the plant marijuana is the most frequently purchased. The dotted line here is the availability of dispensaries, followed by vape and edibles. The tinctures and the oils are a very small proportion. There's an incredible amount of THC being purchased. So this is the distribution of THC being purchased. Just for those of you who are not aficionados, as I was not, there's about 8 milligrams of THC in your average joint. So when I show you the next slide, I want you to hold on to your seat. When we looked at the average amount of marijuana being purchased per day, it was 162 milligrams. So that's 8 times 10 is 80, so 20 equivalent joints per day. On average, a person went to the dispensary 33 times a year, and on average, they spent $3,300 per person. The marijuana is not covered under any insurance. It's a cash business. So these were the numbers that we had on the average purchase, the number of times per day. And then on the right, you can see the predominant type purchase. Again, most of it being plant, followed by edible in terms of volume purchased, and vape. Interestingly, and this is I think a challenge to our clinical community. If you look at the top 2 rows here, we have about 12% of actively licensed physicians in the state had certified at least one. About 785, it was less than 100. And when we looked, many of them had seen the patient and diagnosed the patient. But if you look at the bottom line here, we have 7 physicians that certified over a third of all qualified individuals. And when we looked at those physicians, most of them had never seen the individual before in the All Payer Claims database, nor had they diagnosed the patient with the qualifying diagnosis that they submitted. So I would say we have 2 different profiles moving forward. One are physicians that are actively trying to incorporate this new therapeutic option, and the other are kind of gateway providers, not unlike we had during the opioid pill mills of a decade ago. Our impact, we looked at the impact on PTSD specifically because it was the most common. Preliminarily, it suggests that we might be avoiding 4 hospitalizations for every 100 patients diagnosed with PTSD using medical marijuana. Now, I don't know whether that's a good thing or a bad thing. I don't know if the patients have less anxiety and therefore seek less care, which would be a good thing, or I don't know if they are under the influence of medical marijuana and just decide not to go seek care when it would be more appropriate. We need to do some further analyses on this, but it does look like we may have some healthcare utilization impact. We're now looking at individuals with pain diagnoses to see if we have either utilization differences or potential substitution for opioid use. We want to track to see if we have increases in cannabis use disorder or other substance use disorders. And we're looking at population health impacts. I can tell you now we see about a 25% increase in the number of motor vehicle accidents in medical marijuana qualified individuals versus non-qualified individuals. We don't see any mortality differences yet. And so we're moving forward to try to look at purchasing patterns to see if they're associated with these outcomes. 3% of Arkansas adults are certified, high rates of purchase, 12% of physicians are participating. Early findings with PTSD may show a benefit, and we need to look at longer-term assessments for pain and adverse outcomes that are underway. Our communication team puts out a really good update of everything that we have and our interpretation of what's going on in the environment. So if you're not signed up with our newsletter, I would really encourage you to. It comes out Thursday afternoons every week, which gives people time to digest it on Friday or over the weekend. We also are very active kind of in the social space, hopefully with constructive conversations. I think, we need to come together, particularly as we sail into these new financing challenges in the Medicaid space, to find solutions that are informed by data, that are acceptable politically, but most importantly, that work to serve, the patients and our citizens in a way that meet their needs. So let me stop there. We've got a few minutes. Caitlin, I hope that covered the waterfront. And I would encourage folks on every one of those topics. We've got a deeper dive if you're interested on our website.
Thank you, Dr. Thompson. This has been amazing. I've been taking old-fashioned notes, 3 or 4 pages of those. I have my own questions, but I don't want to speak over anybody. So does anybody have questions for Dr. Thompson while we've got him for another 10 minutes or so?
This is Ann, the Arkansas Department of Health Share. What about the gray market? Any insight on like those vape shops that have been popping up selling those like gray market legal products that contain THC?
Great question, Ann. And we don't have line of sight on that, but just to put a little depth on your question, legally, THC is the Delta 9 version of the cannabinoid. Synthetically, chemists have modified, and that is what is illegal, is the Delta 9 that has psychotic and sedative psychological impacts. That is what is federally and within the state illegal. Chemists have modified that to be a Delta 8. All it is a different carbonic bond in a different place that has similar, if not even potentially enhanced, psychological effects. And because it's technically a different chemical product, it is legally not restricted. And so what you're seeing in some of the vape shops is the entry of these new, not illegal, but equally effective alternatives to traditional cannabinoid products. I would not predict the political battle it would take to make those be illegal, but I think from a clinical, from a substance use disorder, from a societal perspective, those are equivalent products not governed by our medical marijuana program.
Dr. Thompson, this is Dawn Sephora with Our Moms in
Okay.
Hot Springs. My concern is, what is the landscape going to look like if the big, beautiful, not so beautiful bill passes today with cuts to Medicaid?
You and I share that concern. And I think we need to see what is the final result. I would encourage folks to, both if you don't have a relationship or if you do have a relationship with our senators, to make sure that your concern is expressed. If it's an 880 million, I have a rule of thumb that I kind of go by that I'll share. Arkansas is about 1% of everything. I mean, unless you can, it's 1% of the population, therefore it's 1% of everything. You can adjust up or down. We're probably less than 1% of total income. We're probably more than 1% of people on Medicaid. But if you take $880 billion over 10 years, that's $88 billion a year. And 1% of that would be $880 million of federal funding cuts to the state of Arkansas. So I think that just puts in context, an $880 million reduction in federal funding. How would our state respond to that? Because we are so dependent upon the Medicaid, support in our clinical system. We had a couple of questions in the chat. I saw them come by. I'm trying to find them.
I can read them to you if that's easier. Dr.
That would
Thompson.
be much helpful. Thank you,
Yeah,
Caitlin.
Terry wants to know, concerning the maternal health information you shared, how long was the observation period for that?
The study period was from 2019 through 2021, so that's when moms could deliver. The observation period for outcomes for moms, we had kind of 3 periods. One was the prenatal period, one was the delivery itself, and one was the 1-year follow-up after delivery. For the infant, it was 1 year following delivery.
Thank you. And then I do see Larry asked, do you feel like the research is moving to greater restrict access of the THC products you mentioned?
I think the short answer to that is no. I think you've got now medical marijuana in Arkansas, as in many other states, instilled in the Constitution. You have efforts to make recreational marijuana be made available through the Constitution. What I have said, both nationally and locally, is that, if we're going to use medical marijuana as a legitimate vehicle, let's treat it like medical marijuana. I mean, the single thing I would advocate most in this state is that if you get a medical marijuana card, that becomes registered in the PDMP. with 3% of Arkansans, over 3% now with a medical marijuana card, I bet less than 10% of their physicians know that they're using it. And so the easiest way to actually help facilitate that is to have qualification for medical marijuana be a required, notice in the prescription drug monitoring program, so that if a patient comes to me, I can look up to say, has this person self-selected to use medical marijuana, so that I can at least know to ask questions. Right now, I think we have 3% of the Arkansas population using, and clinicians are they are not asking, and most of them for sure do not know that their patients are using that as a perceived, at least for many, medical therapeutic.
Larry did have a follow-up question on that. Are you anticipating any research as far as the substance use disorder population and how the use of medical marijuana affects that population?
We are proposing to do a follow-on study. There is, again, getting back to, medical marijuana didn't come into availability through a traditional kind of clinical trial or FDA approval. It was a voter-led initiative. So currently, if you have substance use disorder or if you have cannabis use disorder, there's no restriction for you getting a medical marijuana card. And there's no way to know whether you got a medical marijuana card. So, I mean, I think, Larry's on to a pathway of inquiry, which we're going to pursue. I hope we don't find what I anticipate.
That is what I'm a little worried about too. I work in acute inpatient psych hospitalization on the weekends, and I'm a little concerned about that as well. So obviously we want to set them up for success, and I definitely think research like that will help us make those decisions for sure.
Let me do one follow-on at
Mhm.
some risk. I think if we find that, then another lever within the state beyond the PDMP suggestion that I just had is, I think, those findings, and even short of those findings, pressure on the medical board to require those 7 physicians. I mean, they are supposed to have a physician-patient relationship. And I think we now have evidence we published in Health Affairs that suggests those physicians do not have a physician-patient relationship.
I do have a quick question just relating to your presentation on, or the part of the presentation on social media and youth. I'm about halfway through that Anxious Generation book, so this answer may be in there. But are we seeing a change, or have you seen a change in attention of our youth? Is it like shorter attention spans? I'm hearing that through stories with teachers that I'm friends with, but I'm not necessarily seeing that in like formal studies. Are you?
The pilot study that the Bentonville School District did when they did their cell phone restrictions, they found reported both from teachers, from moms, and from students increased attention during the instruction time. And from the students specifically, I went up to their parent, teacher, student discussion event on this. The students did not recognize how often they looked at their phones during the school period and how distracting it was when they did. So that I think there's anecdotal information, Caitlin. I don't know that there's broad quantitative information. The other thing that was reported in that pilot study was a significant reduction in disciplinary problems. And one of the highest disciplinary problems that was reduced were drug transactions. If people didn't have their cell phones, they couldn't make the hookup to make the drug transaction at school.
Wow. I wouldn't have even thought that was an issue.
I would
That's
have
how we
never, I
removed
would have
Diane
never,
from that. Yeah.
I would have never thought that either. But that was a eye-opening finding.
Yes. We've got 2 more questions. I know we're just about 30 seconds. I don't know if you have a couple extra minutes to stay on for
Sure.
those questions.
Sure.
Okay. Julie, I'm going to ask you a question here. She's a NICU social worker, and she's curious about the perinatal THC use impact on moms and neonates. Garrett's Law reports are made for positive THC screens at the time of birth, regardless of if mom has that marijuana card or not. Are there any studies tracking behavioral health outcomes for moms who use THC surrounding the time of birth?
So we do. Great question. And luckily, we are a step ahead. We have one of the neonatal intensive care physicians at Children's that's trying to look at the medical marijuana qualified individuals who have active purchases during their prenatal period to set up to be able to see whether there are differences in either birth outcomes. I think her desire is then to look at future developmental outcomes. For most of you, we do have Garrett's Law. However, most hospitals do not screen for substances of abuse because it requires reporting mom to social services. In fact, I'm only aware of one hospital in the state that screens all moms for substances of abuse at delivery.
I didn't know that. I didn't know there wasn't screening happening. And I agree, Julia. I agree with that. Opportunity for bias there, absolutely. Carrie does have a question and kind of just like your take on this, as far as, there's so many warnings and education around SSRIs and other antidepressants as far as their side effects, suicide, psychosis, and others. Why do you think we're not treating medical marijuana in the same way as far as like education and awareness for that?
Candidly, I think we don't know. I think, the experience is mostly communal because the Substance Abuse Control or the Drug Control Act has classified marijuana as a Schedule I drug with no medical benefit. There have been very few studies. In fact, ours is, to my knowledge, the first population-based study on medical marijuana. So unlike the SSRIs or NRIs that have gone through extensive studies and continue to have follow-ons of those studies for adverse outcomes, none of that infrastructure work has been done on marijuana. It has been a politically initiated access point. And, we could have a debate that I could argue one side, I can't argue the other. I almost think if you're going to have it, just don't prostitute the medical aspect of it and say, let's just have recreational and not pretend that it's a different aspect. There may be therapeutic benefits for individuals, but we've not studied it. We don't know the adverse outcomes from it. So we shouldn't give a false sense of safety in making it available with a medical term in front of it.
Great point. We are about 3 minutes over, and I think this is probably the most we've retained after a whole hour. So I think there's a lot of people interested in these subjects. I don't want to take any more time from people. I know everyone's busy. Are you okay if people reach out to you with questions?
Sure. I would ask them to go to Michelle and let her batch them together. And then, we can do some small group discussions if people want, if we see a group of questions that are around a topic. We covered a lot of space today. So if people are interested in the financing piece, and again, almost everything that I put, except maybe the medical marijuana results, are in a dashboard on our website. So you can actually look at your county, your locale, your region, and it may be worth Caitlin having a group, if they want to learn how to best use those dashboards, to pull a group like that together and let Michelle and our visual analytic team walk them through what's there. I think that could be a valuable next step.
Absolutely. I think we definitely have some opportunities built in some of the things that we hold throughout the month. So we definitely can reach out to Michelle, who did put her email in the chat. I appreciate that. Okay, well, this was very thankful for all this information. Thank you for the discussion around that. As I said, this webinar is recorded. It will be on our website within the next couple of days and on our YouTube channel, shameless plug there, if you'd like to go and see all the other webinars that we've had as well. And we thank you so much for your time, Dr. Thompson. Thank you for sharing this with us.
Great. Y'all have a great day. Be safe.